So that Akshay also ran away. Okay. With that kind of a, yeah, see some familiar faces. So I don't know what I'm supposed to be talking now because I only see oculoplastic surgeons who are already practicing in the, so I can, this is just the oculoplastic surgeons talking to the oculoplastic surgeons. So again, I'm not going to be going too much into the importance of oculoplasty, but if in case this is being recorded and viewed by the postgraduates, probably it will be of benefit. So before I start, I should thank Dr. Vidya and the organizing committee for having given us this opportunity. And I hope some use comes out of this program. So we all know this, that it is not, so the focus has to be not one particular age group. It is going to be a wide range of age groups that are involved, starting from the newborn to a very elderly patient. So on one part, we'll have to concentrate only on the functional outcomes. And side by side, now we have moved towards a functional and an aesthetic component. Earlier, it was just managing the disease, but now we have moved from functional as well as aesthetic component. So in order to obtain such an outcome, you need to have a complete knowledge of what is actually in the patient. So examination becomes very important, and considering the field, there's a multitude of disorders which requires a lot of precision in terms of examination skills in order to even diagnose. So if you look at, I'm just going to give some examples and look at what areas we need to concentrate on. The one and only one person is missing. Okay. Thank you, Mukesh. That speaks about how interesting this session is. Anyway, so if you look at the eyelid, it's about the appearance of the skin. The appearance of the skin, probably a lesion like xanthelasma could give you a lesson. You look at the position, it talks about a lot of aspects. The movement of the eyelids in myasthenia myopathy, the Bell's phenomenon speaks a lot. Lag of thalamus could give you a clue. So there are so many such, finer points in examination which gives us a lot of inputs towards diagnosing the condition. Now, if you take the ptosis evaluation, now let's look at the different ways in which a patient presents. You have, this probably is a teenager. You have ptosis in one eye. Then here you have another child with a blepharophimosis syndrome. And then you have another child with a mechanical ptosis. And each of these require a lot of precision in terms of examination. Now, when you're talking about this patient, you are talking about just the ptosis aspect and not associating much with the systemic aspects. Whereas when you're talking about this particular ptosis, you're talking about a syndrome. So you're just not going to talk about the examination of this area, but you're also going to ask for a family history, and you also have to look at the gender and also look at the genetic studies in these patients. So a lot is to do with just one simple diagnosis. Then when you come to this particular aspect, you all know it. It is very easy to diagnose it. It is a neurofibroma, a plexiform neurofibroma. But that doesn't stop there. You need to look at the entire body. Examination has to be done. Look for cafe spots. Look at the fundus. Look at the imaging in order to rule out other glioma and other aspects. And then you also have to look at any association in the family with the von Recklinghausen, or any such details have to be looked into. So it's just one entity where there is a droop of the eyelid, and then we have all these aspects to consider. Now let's look at ectropion. I'm just going to give few examples. Now this ectropion is very different in each of these scenarios. Here you see there is an ectropion, but it's ureblefron. Here you see an ectropion, and look at the way the patient has presented. It's floppy. Here it is mechanical. There is a hypertrophy of the conjunctiva resulting in an ectropion. And here you see it is the upper lid, where there is shortening of the anterior lamella. So there are so many aspects which requires to be looked into. So you have to look at what causes the problem and what is the status of the problem, and you also need to look at all these aspects in order to manage these patients. Now let's look at another scenario. Now, when we talk about lacrimal disorders, there's a wide range, and the management depends upon the age group. Now you have an abscess here, you have an amniotocele here, you have matting of the lashes here, you have absent punctum here, you have a lacrimal abscess again here. Now, how do you manage each one? Depends on what the presentation is like. So, you need to have a good history, you need to have a good examination. Now, these two look very similar. In fact, this also requires an attention in terms of, probably if you don't examine well, you might mistake it for a lacrimal abscess, and you might eventually do something very drastic, and it could be detrimental to the patient. So, the again, another thing is, if you look at this particular child, it could easily be another encephalocele as a differential diagnosis. So, where is the swelling located? That would determine what the lesion is going to be. So, it is very important for us to look at the details while examining. And you also have, in addition, associated congenital anomalies alongside of these problems. And in an adult, it's totally different. So, and what is the presentation like? Watering with discharge, or watering with no other problems. When there is watering, you do a series of procedures, you do a series of tests, and then you come to a conclusion whether you have to go in for a surgery or not. And when you have a scenario like this, you all obviously know what needs to be done. It is management in a different way, where you start off with managing by antibiotics, suppressing the inflammation, and then going ahead with the surgery. So again, lid mass, it is a whole lot of examination skills that we require, and we need to address it as required. When it comes to trauma, again, we deal with trauma. We look at the site, the location where the injury is. We look at whether it's a bony involvement, whether there is a muscle entrapped, whether it is just one single bone involved or multiple bony fractures, whether it is associated foreign body, whether there is any lid tears, whether there is any associated adnexal tears, any hemorrhage. All of these comes out on examination and on investigations. As far as the infection goes, you need to do a proper examination to rule out whether it's a preseptal or an orbital cellulitis. Examination, pure clinical examination will tell us whether it's a preseptal or orbital cellulitis. Before the advent of MRI and CT, I think a lot of diagnosis was made purely on clinical examination. Now we have the advantage of the investigations, which actually augments our diagnosis. But that apart, I think a good clinical examination will differentiate from a very grave disease. Inflammations, again, I think most of us can diagnose a patient with thyroid just by looking at them. So these are conditions which can be diagnosed by a proper examination, clinical examination, and documenting all the investigations, thyroid profile, antibody profile, and then doing a good imaging will help us in. Now here, when we talk about proptosis, there's a wide range of diseases that we come across. You look at this, you know very well it's a Crouzons, where there is you don't have to do any investigation. You take the proper history, you talk to the patients and look at the patient per se, you will say that it is Crouzons. Apers, when it's associated with mental retardation. All of these, with a good clinical examination, will be able to arrive at a diagnosis. Here, you know for sure it's a dermoid. You don't even have to do a CT or an MRI, and you palpate when there is a temporal fullness. You know that it becomes a dumbbell here. It's been a chronic lesion, a dermoid which has crossed borders and gone into the temporal fossa. And all of these, a good history here. The patient has been okay. There was an upper respiratory tract infection, has been sneezing constantly, and sudden proptosis. You know it's a bleed in the lymphangioma. And then you have all these wide range of tests which will give us a clue. A simple resistance to retropulsion will tell you whether it is a hemangioma or some other lesion. So sometimes even imaging, though it enhances well on contrast, you will have a lesion which could have probably caused an inflammation, and on imaging with contrast would enhance very well. Just by resistance to repropulsion, you can make out whether it's just a hemangioma or any other solid tumor like a neurofibroma. Okay, I will stop. So again, you have the evaluation of socket, and each of these examination points will tell us what to do. So we have had simple lesions like these to very dramatic lesions like these, all of which will we'll be able to resolve it with a proper examination and assessment of the patient. So I didn't talk about imaging and other blood investigations because there's not much time. The only thing that I'd like to put across is a high level of attention to detail is required to examine, correlate, because when you see a limbal dermoid and a coloboma, you immediately have to look for any preauricular tags, golden heart syndrome. These are little things that we ought to keep in mind. So examine, correlate, then put your diagnosis and connect the dots after investigations and other. You may have to even refer the patients to other subspecialties, which Dr. Kasturi will be talking about. Thank you very much for the opportunity.
Thank you so much for the detailed discussion on this. I just have one question for you, madam. No, probably two. You have emphasized the importance of clinical examination and its importance. In a country like ours, where the world of ophthalmology has moved from clinical examination to investigations, would you be making your decisions based on clinical investigation alone, where in a developing country like ours, where medical expense is again out-of-pocket expense and is definitely a burden for most people? So how do you go about it, and what is your advice for the practicing ophthalmologist?
Technology investigations will not replace a proper clinical examination is what I would like to emphasize. I'm not saying that, I'm not undermining the role or importance of investigations, technology as such. What I'm really trying to emphasize is if you do a proper clinical examination is when you will be able to arrive at a presumptive diagnosis to guide us in a path to even order an investigation.
That's true.
That's what I would like to emphasize.
Any other inputs from our expert panel? Dr. Bipasha, Savri, Kasturi madam, would you like to add anything?
Everything was so nicely explained, and we also learned so much. It's a small group, but we learn from each other.
That's true.
Like,
Thank you,
yeah,
Kasturi.
I really enjoy all your talks.
Just to add to what you said, the radiology say for example, radiology needs to be performed on the basis of your presumptive clinical diagnosis and also interpretation of those radiology. Very often, even residents and fellows just pull out the report and start talking about it. So I think, I know some of us are gifted to have very good radiologists who can almost give you a histopath diagnosis on the basis of the scans. But I think trainees should maybe, I think that will also come in the purview of your talk about how interdisciplinary, even radiology is a disciplinary. So I think it's important to, we have it covered.
Otherwise, I think we'll be entirely dependent on pathologist or radiologist. I probably would think they should not be giving us the diagnosis before we actually have a presumptive diagnosis. Thank you.
Thank you so much, ma'am.